Hi, today we will read about pulmonary tuberculosis. Tuberculosis (TB) is an infectious disease that primarily affects the lung parenchyma. It also may be transmitted to other parts of the body, including the meninges, kidneys, bones, and lymph nodes. The primary infectious agent, Mycobacterium tuberculosis, is an acid-fast aerobic rod that grows slowly and is sensitive to heat and ultraviolet rays. Transmission and risk factors. TB spreads from person to person by airborne transmission. An infected person releases droplet nuclei through talking, coughing, sneezing, laughing or singing. Larger droplets settle. Smaller droplets remain suspended in the air and are inhaled by the susceptible person. Pathophysiology. A susceptible person inhales Mycobacterium bacilli and becomes infected. The bacteria are transmitted through the airways to the alveoli, where they are deposited and begin to multiply. The bacilli also are transported via the lymph system and bloodstream to the other parts of the body, that is kidneys, bones, cerebral cortex and other areas of the lungs, upper lobes. The body's immune system responds by initiating an inflammatory reaction. Phagocytes, that is neutrophils and macrophages, engulf many of the bacteria and TB specific lymphocytes lyse, that means destroy the bacilli and normal tissue. The tissue reaction results in the accumulation of exudate in the alveoli, causing bronchopneumonia. The initial infection usually occurs 2 to 10 weeks after exposure. Granulomas, new tissue masses of live and dead bacilli, are surrounded by macrophages which form a protective wall around the granulomas. Granulomas are then transformed to a fibrous tissue mass, the central portion of which is called gon tubercle. Gon tubercle. The material, bacteria and macrophages, becomes necrotic, forming a cheesy mass. This mass may become calcified and form a collagenous scar. At this point, the bacteria become dormant and these are no further progression of active disease. After initial exposure and infection, the person may develop active disease because of the compromised or inadequate immune system response. Active disease also may occur with reinfection and activation of dormant bacteria. In this case, the gon tubercle ulcerates, releasing the cheesy material into the bronchi. The bacteria then become airborne, resulting in further spread of the disease. Then the ulcerated tubercle heals and forms scar tissue. This causes the infected lung to become more inflamed, resulting in further development of bronchopneumonia and tubercle formation. Unless the process is arrested, it spreads slowly downward to the hilum of the lungs and later extend to adjacent lobes. The process may be prolonged and characterized by long remissions when the disease is arrested, only to be followed by periods of renewed activity. Approximately 10% of the people who are initially infected develop active disease. Some people develop reactivation TB, also called adult type TB. This type of TB results from a breakdown of the host defenses. It most commonly occurs within the lungs, usually in the apical and posterior segment of the upper lobes or the superior segment of the lower lobes. Clinical manifestations. The signs and symptoms of pulmonary TB are insidious. Most patients have a low-grade fever, cough, night sweats, fatigue, and weight loss. The cough may be non-productive or mucopurulent sputum may be expectorated. Hemoptysis also may occur. The elderly usually present with less pronounced symptoms than do younger patients. Assessment and diagnostic findings. Complete history, physical examination, tuberculin skin test, chest x-ray, acid fast bacillus smear, sputum culture are used to diagnose TB. The chest x-ray usually reveals lesions in the upper lobes and the acid fast bacillus smear contains mycobacterium. The tuberculin test. The Mantas test is standardized procedure and should be performed only by those trained in this administration and reading. Tuberculous bacillus extract, purified protein derivative PPD, is injected into the intradermal layer of the inner aspect of the forearm, approximately 4 inches below the elbow. The intermediate strength of PPD in tuberculin syringe with a half inch 26 to 27 gauge needle is used. The needle with the bevel facing up inserted beneath the skin, almost parallel to the skin. Then 0.1 ml of PPD is injected, creating a elevation in the skin, a wheal or pleb. The site, antigen name, strength, lot number, date and time are to be recorded. The result is read 48 to 72 hours after injection. Interpretation of the result. The size of the induration determines the significance of the reaction. The reaction of 0 to 4 mm is considered as not significant. A reaction of 5 mm or greater may be significant in individuals who are considered at risk. An induration of 10 mm or greater is usually considered significant in individuals who have normal or mildly impaired immunity. A significant reaction indicates that the patient has exposed to Mycobacterium tuberculosis or recently or in the past or has been vaccinated with Bacillus calmette-guerin BCG vaccine. The BCG vaccine given to produce greater resistance to developing TB. A significant positive reaction does not necessarily mean that active disease is present in the body. Most people who are tuberculin significant reactors do not develop clinical TB. However, all significant reactors are candidates for active TB in general. The more intense the reaction, the greater likelihood of an active infection. Medical management. A prolonged treatment duration is necessary to ensure eradication of the organism and to prevent relapse. The increasing prevalence of drug resistance points out the need to begin TB treatment with 4 or more medications to ensure completion of therapy and to evaluate new anti-TB medications. Pharmacological therapy. In current TB therapy, 5 first-line medications are used: INH, rifampicin, pyrazinamide, and either streptomycin or ethambutol. Recommended treatment guidelines for newly diagnosed cases of pulmonary TB consist of a multiple medication regime of INH, rifampicin, pyrazinamide, and either streptomycin or ethambutol. This initial intensive treatment regime is usually administered daily for 8 weeks. If cultures demonstrate that the organism is sensitive to the medications before the 8 weeks of therapy have been completed, either ethambutol or streptomycin can be discontinued. After 8 weeks of the medication regime, pyrazinamide can be discontinued and INH and rifampicin are administered for the additional 4 months. The medication regime, however, may continue for 12 months. A person is considered non-infectious after 2 to 3 weeks of continuous medication therapy. Vitamin B, pyridoxine, is usually administered with INH to prevent INH-associated peripheral neuropathy. INH also may be used as a prophylactic preventive measure for those at risk for significant disease, including household family members of patients with active disease, HIV infected patients with PPD test reaction of 5 mm or in duration or more, patient with fibrotic lesions detected on chest X-ray, patient with whose current PPD results show changes from former test results, suggesting recent exposure to TB and possible infection. Drug users, intravenous injectable users with PPD test results of 10 mm of induration or more. Patients with high risk comorbid conditions with PPD results of 10 mm of induration or more. Other candidates for preventive INH therapy are those aged 35 years or younger with PPD test results of 10 mm of induration or more, and one of the following criteria. First one is foreign-born individuals from countries with high prevalence of TB, high risk medically underserved populations, institutional patients. Prophylactic INH treatment involves taking daily doses of 6 to 12 months. Liver enzyme, blood urea nitrogen and creatinine levels are monitored monthly. Sputum culture results are monitored for Acinetobacillus bacillus to evaluate the effectiveness of treatment and the patient's compliance with therapy. Thank you.